Okay, of how it is that medical decisions are made. This is going to be from a doctor's perspective, but the goal is to give patients insight into how medical decisions are made in the medical community by medical providers. And this is not applicable to rare disease patients only. This is actually applicable to anyone who interacts with the medical system, but because rare disease patients and their families and caretakers interact so often with the medical system, it's especially important for all of us to understand how it is medical decisions are made, what ideas and factors are taken into consideration, and how does this contribute to both successful interactions and problematic interactions, like a child abuse accusation, but also just a medical conflict in general. So, all right, what is medical ethics? So medical ethics it's a study of how to make medical decisions, is a very simplistic definition, but that's essentially what it boils down to. How do we make good medical decisions? How do we make medical decisions with good outcomes? Okay, so it's a guide for medical providers and a guide for patients, and it's based on 4 basic principles. In the United States, we use a system of medical ethics that boils down to 4 simple principles. And those 4 basic principles are beneficence, non-malfeasance, autonomy, and justice. And those are big words, and some of them are academic sounding, but they represent very simple concepts, some of which are pretty common sense, but it's good to see the technical terms that are being used and how they're being described and taught in medical settings to medical providers. All right, so beneficence. It's essentially the obligation of healthcare providers to help people in need. Pretty common sense, right? But the basic question that doctors and other providers have to ask themselves when they're considering the principle of beneficence is, will the proposed treatment help the patient? Is what I'm going to do actually going to help you? Again, it seems pretty common sense, but as you see, when we get into complex situations, there can actually be a lot of complicated interaction between the 4 principles, so knowing just the basic questions that are associated with each one becomes important. So will the proposed treatment help the patient? Non-malfeasance. The duty of healthcare providers to do no harm. This is the one that most people are familiar with, since it stems, in some ways from, the Hippocratic Oath, first do no harm, which is an ancient form, a code of medical ethics. But this is, codified these days as the duty of healthcare providers to do no harm. And the basic question is, will the proposed treatment harm the patient in any way? Again, seems like common sense, but, they actually, beneficence and non-malfeasance come into play against each other and have to be weighed against each other all of the time. For example, if you have an appendix that's about to rupture, will the treatment of removing your appendix help you? Yes. But will the treatment of surgery harm you? Well, actually, yes, because the doctor's about to take a knife and slice open your abdomen. That is harm, objectively speaking. However, we would all agree that in that case, the harm of slicing your abdomen open with a scalpel is actually less important than the good of removing your appendix before it ruptures, right? Okay, so autonomy. It is the right of patients to make choices about their medical care. And you can see there's an asterisk there, and that asterisk is important. Basic question, what does the patient think about the proposed treatments? Okay, autonomy is the principle that is most important in medical care for adults who are legally competent but also have medical capacity, which is 2 concepts we'll talk about later. It is not really at play as much in the medical care of children for the simple reason that children are not adults. They're not considered to have legal competence or capacity to make their decisions in most cases. And that absolutely does affect why pediatric medical decision making is quite different from adult medical decision making in some cases. Okay, justice. So the obligation of medical providers to provide medical care that is fair to patients and to society. So is the proposed treatment fair to the patient? Is it fair to society? And as most of you are aware, we've been going through as a nation a lot of healthcare reforms where we've been talking about, the benefits and burdens of healthcare treatments and healthcare plans and how we provide care and how expensive it is and who gets it and who doesn't and how much of it they get. Justice, the justice of medical care, the principle of justice is actually really important when we're thinking about how do we give fair treatment to the patient without overburdening society in ways that are not fair. Okay, so how does medical ethics work? In the nitty-gritty reality of being in a hospital or in a clinic and you're working with a care team, how does medical ethics come into play? So the 4 principles are weighed against each other when making choices, kind of like the appendix example that I used. You can say, a treatment can be helpful, remove an appendix that's inflamed and about to rupture. It can be harmful, slicing somebody's, abdomen open with a scalpel. It can also be just or unjust. If you take the patient who has an ear infection into the emergency room before the patient who has the appendix that's about to rupture, that's not necessarily a just application of medical care in those circumstances. One patient is emergently ill, the other is not. So justice would say that you take the patient who's emergently ill before the one who can wait. And things like autonomy would come into play about, what does the patient want to have done if it's an adult. Okay, medical ethics also, it helps medical providers and patients, they need to work together to find the balance. And this actually plays out really importantly in the differences between adult care and pediatric care. How they work together and how we find the balance is really crucial to helping our care teams work toward good outcomes. So when you have a difficult case that we can't figure out how the principles should be weighed together, when we can't figure out, say, is it just to put people on a transplant list who need a new liver because they've consumed a lot of alcohol, we would consider maybe that a new liver, a liver transplant to a patient who has deliberately made a choice in some ways to damage their liver may not be as just as giving that liver a limited resource to a patient who was born with biliary atresia and has a genetic disease they could do nothing about. Do you see the difference there? Difficult cases, however, would be referred to either an ethics committee. Hospitals have ethics committees. Most hospitals these days have at least some form of an ethics committee or an ethics consultant. But there are also larger national committees in places like Albany Medical College, which is my alma mater. They have their Alden March Center offers ethics consultations to anybody across the nation, medical providers and patients. There also is the U.S. judicial system. And the U.S. judicial system has actually played a really important part in shaping how care decisions in this country are made, what patient rights are, what provider rights are, how do we distinguish between the two, and who is held responsible for medical care decisions when they go bad. A lot of that has been determined through landmark court cases, a lot of them over the last 50 years, some of them before that. Okay, so adult medicine versus pediatric medicine. Adult medicine. In adult medicine, it's typically thought that autonomy is the ethical priority, meaning that when you put all 4 principles in a row, the one that counts the most for adults is autonomy. What does the adult patient think about their medical care, and what treatments are they willing to engage versus do they want to refuse? The adult has to have legal competence and medical capacity, i.e. Medical capacity being usually the one that's most important in medical decision making, is then if the doctor explains to you what your options are and what each option means, do you have the capacity to think through the choices and come to logical conclusions? That does not mean you have to agree with the doctor, but it does mean that you have to understand what the consequences of your decision are in a rational way. Okay. So U.S. courts have decided throughout the years that we allow adult patients to refuse medical care even if doctors disagree. And this is played out in some really dramatic ways, one case in which we'll talk about, but it plays out all the time in different ways. So if the doctor says to you, I really think you need to go on chronic, take a Z-Pak to see if we can get that pneumonia under control, and you're like, no, I don't believe in antibiotics. I want to use oregano, essential oil, and I'm not going to take these. Your doctor cannot force you to take the antibiotic. He can't, or she can't. You have a right as an adult to make a decision that is against doctor's advice and against doctor's orders, as long as you understand that if you decide to use something other than the antibiotic, then there may be a worse outcome, or at least in the doctor's opinion, there's going to be a worse outcome of your pneumonia. Okay, so medical providers for adults should aim for patient-doctor relationships based on mutuality. This is where doctors and patients are partners in medical care. And this is really important in adult care because, like I said, adults have the right to choose or refuse medical treatments, even if doctors don't agree. So the most successful and productive patient-provider relationships in adult medicine are ones where the doctor and the patient approach each other as useful, necessary members of the care team, and they have open, thoughtful discussions about the outcomes and the care decisions that we're looking for. What is it that you're here for today? How can I help you with that? Here are your care options. What do you think about those options? How can we, the patient and provider together, accomplish the best outcome for you, the patient, in our care relationship? Doesn't always work that way. This is the ideal. As we know, real life can be messier, but this is what the ideal is. And honestly, most doctors don't show up at work or go into medicine thinking, I want to stomp all over patient rights. That's not it at all. This is what most patients and providers do aim for. Okay, so here's an example case in adult medicine that really highlights a landmark court case that kind of cemented autonomy as the most important principle of adult medicine. In 1983, there was a Californian resident, Elizabeth Bouvia, with cerebral palsy. She was a 26-year-old. She was extremely intelligent. She'd been to college. She had been married. She, had been working and living an adult life. But at this point, at age 26, she was significantly paralyzed from her cerebral palsy. She was separated from her husband. She was alienated from her family. She was incredibly depressed, and by her own admission, she was quite miserable, and she wanted to die. She could not take care of herself. Without a caregiver, she could not take care of herself. So she was admitted to a hospital where she informed the team that she wanted to die. She wanted to starve to death. She was not going to eat. She was happy for the hospital to keep her comfortable, but she was not going to accept any nutrition. That was the end. And the hospital at that time in 1983 was like, no way. You could live another 15 to 20 years. Yes, you're not happy, but we're not going to allow you to die. That is not a decision we're going to support. So she refused feeding. Eventually, they shoved an NG tube down her nose and were giving force feedings. She came in and out of the hospital a few times, fighting this over. She went to court. Originally, the court sided with the hospitals and said, the providers they do not have to let you die. They can, in fact, force some nutrition on you, and because your prognosis is so good being you could stay alive for longer. And we are going to allow the hospitals to make the decision to override your autonomy in this case. Well, eventually, Elizabeth kept appealing. She went back to court. Eventually, the appellate court sided with her, and they said, this is an adult. She is very competent. She has more than enough capacity to understand the consequences of her choices, and she, as an adult, is refusing medical care. She understands that she will die if she does not take in any nutrition. That is her decision. You must respect it. You may not force feed her. Well, and that was basically one of the cases that really cemented the idea that an adult patient may refuse, which there's a difference between ask for or force treatment versus to refuse treatment, and we're going to get to that. But an adult patient may refuse treatment even if the patient will be harmed as a result, even if the patient may die as a result. So this was really a victory for adult patient rights, that you have the final say on care that you accept. There are exceptions that have to do with mental health issues, but again, it comes back to legal competence and mental capacity. So pediatric medicine is not the same. And this is really important because as I speak with a lot of caregivers, a lot of parents of children who have rare or complex medical conditions, it can be very confusing to them why they are allowed to have the final say on their medical care, but they are not allowed to necessarily have the final say on their child's medical care. It's a difficult concept, so this is important. Children are a protected population under state and federal laws, and basically there's more than one type of protected population. Children, prisoners, those who are mentally incapacitated, so adults with severe mental illness or adults with intellectual disability can all be considered protected populations because they do not have in their capacity at that time the ability to understand and rationally make choices for themselves, knowing the outcomes. And prisoners, because they're not free to make whatever choices they like, they're incarcerated, are considered protected also. But for this, children, they don't rationally understand everything about their short and long-term interests and how their decisions affect those. Because of that, the state and federal government have decided for a long time that they have a role and an interest in protecting children. So i.e. not allowing other people to damage their short and long-term interests. The state wants to protect that. So because of this, parents do not have full autonomy to make choices in a child's care. Your child is not you, and even though our children, we love them deeply and they are part of us biologically, they are not an extension of ourselves. They have their own individuality, they have their own rights, and those rights need to be protected. You cannot decide for your child the same way that you decide for yourself. Okay, so instead of autonomy in pediatric care, children require a legal standard called the best interest standard. And it's pretty much exactly what it sounds like. You have to consider what's in a child's best interest, not your best interest per se, the child's best interest. Short-term interest, long-term interest, medical interest, and non-medical interest. It is not an easy concept, even though it's a simple concept, it's not necessarily easy in application. There can be a lot of different opinions about what a child's best interests are. So doctors and guardians must work cooperatively to decide treatment that's in a child's best interest. Again, this is the ideal. It doesn't always happen, but really this is what we should be aiming for. We all sit down at the table, we have a child's best interest in mind, and we talk through the options and how they're going to affect the child. All right, so when there's a disagreement between parents, guardians, and medical teams, the medical personnel are legally required to examine if guardians really have the child's best interests at heart. So this is where it can connect to the accusations, because if you are arguing with your child's doctors about a specific treatment, even if the doctor, likes you, has a good relationship with you, if the doctor really feels that you're making a bad decision, the doctor is legally required to sit down and think about, is this parent really acting in this child's best interest? They have to. That's an ethical priority. It's a professional obligation. They are mandated reporters. They need to think about this. So if a doctor decides that, either you aren't acting in your child's best interest or maybe you're not, they have to consider consulting, bringing in other people to help them, examine the situation more carefully. So that can include the hospital ethics committee. Perhaps you want to make a decision about whether it's time for a child to move from a curative care to palliative care and perhaps toward end of life and hospice care. Maybe the situation isn't completely clear. We don't know what to do. Is it okay to move the child toward palliative care and perhaps hospice care? Is it not? You could bring in the hospital ethics committee to sit down, listen to the whole story, examine the 4 principles of medical ethics, hear everybody involved, and try and come to a decision. If they suspect that maybe you're not acting in the child's best interest in a way that's abusive, they might be bringing in somebody like Dr. Booth, the hospital child protection team. They might even be bringing in DCYF, or the Child Welfare Agency, or they may even go to court to a judge to ask for a specific court order to force a medical decision or a type of treatment over your objections. And these things all have happened and do happen, and they all have to do with considering the child's best interest. So here's our pediatric example, Gabriel Zepeda. He, in 2012, was a 2-month-old son of Jehovah's Witnesses in Texas. He was born with congenital heart defects, and because there were going to be blood products involved, his parents, in line with their Jehovah's Witnesses beliefs, they refused surgery. They were informed that their child would die without surgery on his congenital heart defect. They were informed that, there could not be an outcome in this case in which he survived unless they did the surgery. They continued to refuse. They said, in their opinion, based on their religious beliefs, it would actually be better for their son to die than for their son to receive blood products. Okay, so the hospital did not feel that they were acting in the child's best interest. They went straight to the judge. They said, here's the situation. We want a court order to override the parents' objections. We want to be able to give the child surgery and blood products despite the parents saying that they're not going to consent. And you know what? The court gave them that order. And frankly, the court will always give the order in that particular situation and others similar to it. So back in 1944, the Supreme Court of the United States, SCOTUS, actually adjudicated a case that came from here, Massachusetts, Prince versus the Commonwealth of Massachusetts. And it had to do with a Jehovah's Witness family, although it didn't have to do with blood products. It had to do with whether or not parents could, engage in what the state viewed as child labor due to practice of their religious beliefs, freedom of religion. So it came down to basically overriding what the state felt was in the child's interest based on religious feelings, practice of religious beliefs, and religious freedom. And the majority opinion came out this way. Parents may be free to become martyrs themselves, but it does not follow that they are free in identical circumstances to make martyrs of their children before they, the children, have reached the age of full and legal discretion when they can make that choice for themselves. And this is really a guiding principle here. This is really one of the things that helps define the best interest standard in the United States. You can make a martyr of yourself, i.e. refuse medical treatment, go do silly things, jump off of cliffs, go skydiving, that sort of thing. You may do those things, but you do not have the same permission to endanger your child, make a martyr of your child, or otherwise harm your child before the child can make any sort of rational decision about their own interests. Okay, so if a parent is not free to do those things, then what is the parent or guardian's role in a child's medical care? So the U.S. courts view parents as the best decision makers for children in most cases. Pretty much from time immemorial, it has been commonly held across civilizations, cultures, societies, religions, judicial systems, that generally speaking, parents are the ones who are most invested in their children. Biologically, emotionally, financially, they support the child. They are the ones who, generally speaking, have the child's best interest, short and long term, at heart, and they take them seriously, so they are usually the best decision makers. Okay, so the parents have a couple of duties when it comes to how do they exercise their decision making for children in medical situations. Parents have a duty to seek medical care for a child when needed. If your child comes home and his arm is broken and you believe that either you can tell it's broken or you believe it could be broken and the child is clearly in need of attention, medical attention, you have a duty to seek that medical attention. It is not actually allowed for you to sit at home and do nothing. You must take your child in for medical care. I think we've all seen some of the cases in the news when parents, for religious or other reasons, have known a child is severely ill, but instead of taking the child to the hospital to receive medical care, they have engaged in sort of alternative practices, and sometimes tragically the children have died as a result. That is not allowed. You may not exercise that right as a parent. You have a duty to seek medical care for your child when it's indicated. Okay, so you're taking your child for medical care. Well, you do have a right to choose where and by whom care will be given. Now this, for the most part, it's going to be, there's going to be some restrictions based on your insurance plan, what hospitals take your insurance, and how emergent the child's care need is. If your child is hemorrhaging, and it's clearly an emergency, then you need to take your child to the nearest emergency medical center or call 911. However, if Johnny is here and he has a broken arm and we know it's broken and there are 3 hospitals, within 5 miles, generally speaking, you have a right to choose which of those hospitals you want to take Johnny to if your insurance covers all of them. If your dad's golf partner is an orthopedic surgeon at hospital number 1 and you really want him to see Johnny, then you can take Johnny there. Alternatively, if you really do not want him to see Johnny, then you can go somewhere else. So, like I said, there are some exceptions. You need to seek emergency medical attention without waiting to drive 10 miles to a hospital and pass 5 on the way, but you do have a right to choose in most cases. And parents, and we're going to get back to this one, it's a little complicated, but parents have a right, generally speaking, to choose between treatment options according to their understanding of a child's and family's interests and needs. So if Johnny is 15 years old and he's broken his arm, and he is a star athlete who's been recruited by multiple college baseball teams, and it looks like he could be going professional at some point, then the emergency room doctor comes to you and says Johnny's arm is broken. We have 2 options. I can refer you to the orthopedic surgeon for some aggressive, surgical options for treatment, or we can try putting on a cast and see you back in 6 weeks to just kind of see how it pans out. Well, you may, given Johnny's best short and long-term interests of professional baseball, you may say, look, it's really important that he can use his arm. Sign me up for the orthopedic surgeon, stabilize the arm now. We're coming in tomorrow. We're going to be, as aggressive as the doctor feels we need to be to really protect this child's long-term interests. On the other hand, if Johnny is a couch potato and does none of these things, you may decide that it's in his best interest to not rush to a surgeon and to really go home, try 6 weeks, see how the arm turns out, come back, and then consider whether more needs to be done. So the same situation, but you're choosing different treatments based on your understanding of the child's interests. That typically is allowed. There are exceptions, but that is a legitimate use of parental and guardian authority. All right. Parents do not have to consider medical factors only when making care choices for children. And this becomes important. It's actually sometimes this is more important to talk to doctors and medical providers about, because I think in their best intentions and given all of their professional training, they sometimes forget that parents can consider other things than just medical factors, i.e. if Johnny's a professional baseball player or wants to be or is possibly moving in that direction, and Dr. Very Conservative is on at the ER that day, and you ask Dr. Very Conservative if you can have a referral to the orthopedic surgeon, and he says, absolutely not. We simply don't do that. You must wait 6 weeks until, the child's arm to see whether he needs surgery or not. It's just, that's the best medical treatment, and we're not going to consider anything other than that. That's really not the best practice of care. There are other things that parents are allowed to consider when they're looking at a child's best short and long-term interests, and that includes some of the family's interests too. The parents are often responsible for more than one child, and those things can all be considered to a degree when you're making care decisions. Okay, So here's the exception, and this goes back to like Gabriel Zapata and other life-threatening situations. If your child has a reversible life-threatening situation, you do not have the choice to consider multiple alternative options. If the doctor says to you, Johnny's appendix is about to burst and he must have surgery right now, you don't have the option of waiting 6 weeks to follow up. You must act in an emergency situation that is reversible. Now, there are situations in which case the situation might be emergent or it may have a very poor negative outcome or prognosis, but it's not necessarily a reversible situation, in which case you do have more options. So if your child has a form of cancer and it's spread throughout the body, and now there is a tumor that's starting to press, say, around the aortic area, and it's going to possibly end in your child's death sometime soon, you may decide that you want to pursue surgery, or you may decide after consulting with the healthcare team that you can go in and operate on this tumor, but there's just going to be another one 6 weeks later or 6 months later, and maybe that's not in your child's best interests. That is an emergent situation, but it's not necessarily a reversible situation. So there is a difference. But in a reversible situation, the Supreme Court's decision pretty much applies in most cases. Your child has a treatable, life-threatening condition. You must treat it. Most of us wouldn't argue with that, but obviously there are cases when parents don't feel that way. Okay, so what is the physician's role in a child's medical care? So licensed MD and DO providers is who we're discussing here. I know there are a variety of alternative medical practitioners, but I'm discussing licensed medical providers. They have a specific set of rights and responsibilities. A doctor has the right to assess the patient's medical status. And this goes for children and adults. But if you bring your child in, you say, I think that my son needs medical care, I think that my daughter needs some medical attention, here's what I think is going on. The doctor is the one who has the right to assess your child to see if that is true, that there is a medical problem that appears to be occurring. So you can tell them what you think is going on, but you're not the doctor. You don't get to make the diagnosis or necessarily say that, yes, there seems to be a clear medical problem here. All right, so then if the doctor decides that, yes, there does appear to be a clear medical problem here, the doctor has the responsibility and the right to collect medical data on the problem. That can be done through tests and through clinical assessments and through other means. But the doctor is the one who can say, all right, your son appears to have a broken arm. We're going to run the appropriate tests. We're going to collect the necessary data to know if that is a true statement or not, if that is the right diagnosis or not. We're going to order some x-rays. Maybe in some cases you would order some imaging, some other types of imaging, soft tissue damage. There's a variety of things that can be done, and this is true anytime you present a child for medical care. The doctor is going to want to determine what the problem is if they don't know, or how to treat by collecting data and testing and evidence, and they're the ones who get to decide what's the most appropriate testing and how to collect it, what is the data that they're looking for, and how should it be obtained. All right, and then finally, a doctor is the one who has the right to decide what the reasonable treatment options are based on the medical ethics and care data that they've collected. So basically, if it is the doctor who gets to decide whether or not surgery versus casting is appropriate for your child. Now, you have the right to seek multiple medical opinions, but you do have to understand that it is the doctor who presents these treatment options to you. So if you bring a child in, say for a medical condition and we don't know what it is, they do a bunch of testing, they determine that your child has a condition that's not emergent but is treatable, and they give you a range of treatment options. If you don't like any of those treatment options, you can look for another opinion, but you cannot say to the doctor, no, I will not accept those treatment options. I want something else. You must provide something else. You do not have the right to force a treatment option on a licensed medical professional. So if the doctor says to you, your daughter Sarah is very seriously failure to thrive, we would like to consider 2 treatment options, place a G-tube, or perhaps 6 weeks of intensive feeding therapy. As I said before, you don't have the right to say, no, I want TPN. You can't force the doctor to do that. You have to work within the reasonable treatment options that the medical provider is saying are the best ones for the situation as they've determined it. Okay, and then also doctors have a responsibility to protect patients who are children, as we discussed before. Licensed medical professionals, they are all mandated reporters. If they believe that something is occurring to harm a child, they have a professional, ethical, and legal obligation to consider how the child can be protected. So medical decision making, given that those are the rights and responsibilities, how is the best way to go about medical decision making? The best way, of course, is cooperatively. Whether you're an adult or a child, whether you have a rare disease or a common ailment, whether you are seeing 15 specialists or simply one, it's always best when it can be a cooperative approach. So the patient and family and the medical team make choices together. That is the ideal for which we should all be aiming, medical providers and patients alike. This means that patient and family priorities count, not just medical priorities. And sometimes, like I said, this can be overlooked, especially when we're really zealous about, what are all the best medical treatments, that there are other things that come into play, but a good patient and family-centered care team is aware of that. And care can be different for individual patients and families based on unique needs, circumstances, and values. Like we discussed before, a child with a broken arm who is going into professional baseball versus one who is not, may have a different care plans depending on their individual needs. So you can come in for the same ailment, be seen by the same doctors, and when child and family-centered care is being done appropriately, when patient-centered care is being done appropriately, you may be able to leave with two very different care plans and that still be okay. It doesn't have to be one size fits all. So providers decide the range of care needs and the patient and family choose between the options. I think this is actually one of the most important principles for not only medical ethics, but for decision making in general, is that this is the division of responsibility when it's working well. The doctors provide the range of care options based on your medical needs as they've assessed them, and you choose which of the options best fit your needs if you're an adult, your child's needs, and your family's interests, working cooperatively together. So the patient and family-centered medicine should be the standard of ethical medical practice throughout the United States. I would say for the most part, this is absolutely the goal. I mean, I have yet to see a medical facility, in the last 10 years that I haven't walked through where they have some beautiful shiny plaque on the wall that tells you how devoted they are to patient and family-centered care. Now, so it's a very well-known principle. I would say that it's not always a very well-executed principle, and that's not necessarily intentional, but just like care coordination, how it takes a lot of time, they don't really get reimbursed for it, they don't necessarily get a lot of training on it. Doctors don't get as much training as they need on patient and family-centered medicine. What does it look like? How do we practice it? How do we go through difficult circumstances? How do we go through common circumstances? Patient and family-centered care requires a lot of thought, it requires a lot of time, it requires a lot of coordination, conversation. We're really getting into the individual circumstances of every patient and every family that comes through. It's hard, it's not easy, it's not always intuitive. So it doesn't always get done, and that's sort of the sad reality. But you as a patient and as a caretaker can advocate for patient and family-centered care. You can go to that patient bill of rights that they hand out. You can go to the nice shiny plaque on the wall and say, hey, I know this is a priority for you, for the medical team, for our hospital. I don't really feel like we're getting patient and family-centered care right now. Do you think that we could sit down and talk about it and see how we could, really sort of refocus our care goals on the patient and the family and their unique needs. Okay, so problems. Back in the real world. Often there are a lot of care problems. Obviously, we all know that, or we wouldn't be here today. And the problems usually have factors on both the patient side and the family side and the provider side. It's not that often that one side is uniquely and solely responsible for a care problem. It happens, but it's not usual. So often, like I said, there can be a lack of training for providers in patient and family-centered care and how to actually practice it with real people in real situations. When you have 10 minutes to get through rounds and you have 15 patients to see, and your attending is going like, where are the medical orders? You haven't put them in the computer. It can be hard, and you can feel stressed as a medical provider to provide that level of intensive patient and family-centered care. And that can and does cause problems in care. So there can also be, as part of that, the failure, like I mentioned before, to include patient and family priorities, because it's patient and family priorities, patient and family needs that make care plans look different from each other. That you can have 5 children with asthma or 5 children with type 1 diabetes, and the care plans may look slightly different for each other depending on the patient's priorities, the family's needs, the child's needs. But if you don't take the time to know what those are, you may not be getting the best care plan for each patient. And then, of course, there is the fact that in many situations, parents misunderstand the best interest standard. They really struggle, and it's not intuitive to them that they don't have the final say in their child's medical care, and that they don't always have the right to refuse care. They don't always have the right to demand specific treatments that they want. Such and such other family, their doctor put in a very specific type of, an insulin pump. I want an insulin pump. I think that's what my child needs. I demand that that's what you give my child. And the provider just thinks that that's not appropriate for your child and that that is not in your child's best interest, that patients and families really, they'd have a hard time understanding why they just don't get to demand what they want. And that it comes from, I think, sometimes the fact that patients and that providers don't always explain how medical decision making works, and they don't always explain clearly to patients how it is that choices get to be made, because it's not usually out of a desire to harm anybody that parents want this right. They think it's what's best for their children. And then, of course, then there's providers who have concerns over legal liability. If the doctor thinks that they give Sally a G-tube, that they're going to get in trouble, it could be medical neglect, it could be medical abuse, it could be this or that, and they think that they could be legally liable for their actions, they're going to be a lot less willing to go down that path sometimes. And it can be a hindrance to really considering unique needs of different patients, families, and care teams if the providers perceive a lot of liability. Then, of course, there are genuine disagreements over what the patient's medical needs are, like in a lot of the cases I talked about earlier today. If we think about back to Elizabeth Ray, does she have PANS? Does she have a psychiatric disorder? What are the child's actual medical needs or the adult patient's actual medical needs? And then, of course, disagreements over what's in the child's or the patient's best interest, but specifically for children, what is in the best interest of this child? There may be so many different opinions about that. Every provider may have a different opinion. If there's two parents involved, both parents may have a different opinion. If grandma's involved, grandma may have a different opinion. There can be many, many, many people who have opinions over the child's best interest and want their priorities taken over everybody else's, and this often causes some very serious problems. And of course, there's more. And that's pretty much where we're going to leave it for right now, because I think we understand that the problems are real. But what I wanted to highlight in this talk was the reality that there are specific responsibilities, rights, and factors that come into how medical decisions get to be made in a care setting, and that when we understand those things as patients, as families, as caregivers, we are better equipped to go back to a doctor in a difficult care situation and discuss why the outcome doesn't look the way that we want. We are equipped to say, I understand that you have to consider my daughter's best interest, that you may not think the treatment I'm asking for is medically reasonable. I feel like perhaps you're not really considering our family's unique needs and priorities. How can we have a discussion about this, and how can we come to an outcome we all agree on? So I think that from my perspective as a patient advocate and a medical ethicist, it's important that patients, families, and caregivers understand the medical ethics principles that are involved in decision making, because it increases the likelihood of there being a positive outcome, and it increases the ability of everyone to work together cooperatively. So that's where I'm going to end for today. And Julie, do we want to do questions now, or are we done? Okay, so if people have any questions, go ahead. We have a couple of minutes. Yes, Janet.
This is an old case, but can you comment on the Billy Best case?
You want to give me some of the details of that case? It's not coming to mind.
Billy Best was 14 from Bridgewater, and he...
Go ahead.
This is in the 70s, I think.
A little before my time.
He's famous. And he, 14, 15, got lymphoma or leukemia and refused treatment. Mm-hmm. And he was afraid he would be taken into, foster care or custody, and he ran for it. And he ended up running away to Arizona, waiting till he was of age and then coming back. So I'm just wondering, if a child absolutely refuses treatment, do you tie him down?
Well, actually, so there was a case recently in Connecticut where they did exactly that, where a teenage girl had Hodgkin's lymphoma. It was deemed to be very treatable. She absolutely refused treatment. The court felt that even though she was 17, that she did not have capacity, that she individually did not truly understand the consequences of the decisions she was making. She did absolutely refuse treatment, and they absolutely did bring her into the hospital under a court order and sedate her and give her chemotherapy. Now, this was a huge debate, because there were a lot of physicians at the hospital and outside who were very uncomfortable with this. A child on the verge of adulthood who was absolutely refusing that these physicians would, so to speak, violate the child's bodily sanctity and force this treatment. They literally had to tie her to the bed and sedate her. But, the case went through many different hearings in court, and it was thought in that particular instance that the child was being unduly influenced by her mother. There was a lot of suspicion of, not perhaps medical child abuse, but, medical neglect, and, that the child really did not understand. And so sometimes, yes, they absolutely will force the treatment if they believe that the child cannot understand the consequences of his or her choice. Sometimes they make different decisions. There have been a couple of cases where a child on the verge of adulthood has declined treatment, and a court order has supported that. But it's going to depend very, very much on how that child functions, whether the court feels, and it's going to be a court order usually in these cases. It will be a court decision because this is based on the Supreme Court decision about not being able to, refuse treatment in reversible life-threatening situations. Does the court feel that that child has both medical capacity and is approaching, even if they don't have direct legal competence, that they are competent to make those choices? Yes, Amanda.
Complicated question, but are there any organizations that really promote?
Okay, that's right.
Are there any organizations nationally or in this area that promote advocacy for children or families in situations like this that people can go to? I know there's sort of an underground network of people that do this type of work, but do we not have any actual...
Do you mean legal advocacy?
Yes, and just, I think education in our communities is really important. What we're doing here today is very important. But I also am curious, is anybody looking at the long-term ramifications from children that have unknown, undiagnosed, or rare illnesses? Sometimes there's also a mental illness combination in there, which is common. And what kind of responsibility does the medical community have to the patient and the family when there's trauma done or there's harm done through this process? Has anyone ever studied that? Has anyone tracked that, looked at that, or does it not matter because the intention is good of the provider?
So that's a little bit of a complicated question, but I would say that most people would not say it doesn't matter. I think most providers, medical ethicists, and patient advocacy communities would say that yes, of course, trauma does matter. They would also say that it's really complicated, however, because a child may have been traumatized by past medical experiences and other issues and still not be competent or have capacity to really understand the choices such that they can refuse medical care. And actually, I think Dr. Barnum is going to address this a little bit in his talk tomorrow about how medical trauma and really negative interactions with the medical community can negatively affect young adults as they're trying to make care choices. But I would say that yes, it matters. As far as specific organizations devoted to that, I mean, Rare New England helps with patient advocacy. There are many different legal groups and entities that are interested in family law and civil liberties and, the rights of children, the rights of parents, the rights of young adults. And there are a lot of places in Boston that have done that. I mean, John Martin does some of that. So it's definitely been looked at. There have been studies done on the effects of medical trauma, not only on children, but on parents. You can look in the literature for that, but I would say it's still it's a pool of murky water. It's really going to come down to that child, that situation, exactly what needs to be done and exactly what's going on. Because we have not successfully made generalized statements except to say that in reversible life-threatening situations, we should preserve the child's life until they can make their own decision whether they want to stop treatment.
Here, I know a lot of families that there's a genetic disorder in a family. 3 children are affected, for instance. If they're questioned about one child, say it's the oldest child, and then they have 2 other children with the disorder diagnosed, they are then afraid to bring those children forward for care. And I think it's harming the other children in the family. And I'm concerned, I'm a nurse myself, and I'm concerned about children that need care, not getting care, based on the fear of the families that are involved, and I see it happening a lot in our communities.
I see that happening too. I've absolutely have worked with families, many families who are afraid either to seek care for other children or for a child who's gone through a past, a suspicion of abuse or lack of, verification of their medical problems. And I would say that's a really complicated multifactorial problem that doesn't have specifically an easy answer. Again, I try and work on those as a case-by-case basis, but I would actually say that that's something medical providers do need to understand. It's one of the reasons we're here today to talk about some of the negative outcomes of a false abuse accusation. One of the absolute negative outcomes, and Dr. Barnum is going to talk about this as well, I'm almost positive, is that a parent or family or a patient may in fact be reluctant to seek future medical care even when it's truly needed if they feel that they are going to be accused again or not believed or subjected to some horrific, non-helpful response. So that's a very real problem, and unfortunately I don't have a good answer except to say educate providers, educate patients and families, and try and reduce the number of these really negative interactions. It's not exactly satisfying, but it's definitely a problem that
I was just wondering if there's any kind of an ethics radar on this stuff? Or?
Yes and no. I mean, I did my thesis on this. I had a lot of discussions with some of the faculty in Albany. I would say a lot of people really don't understand. Child protection medicine was not a program in which you could be certified until I think it was 2008, 2009. It's a newer field. I would say that the absolute ethics of it have been looked into in some specific cases, but when we get into medical child abuse or Munchausen's cases, that there really hasn't been a great meeting of the ethics and child protection minds to really drum out some of the ethical questions. And I think that really does need to happen, but it hasn't happened yet. Anyway, okay, Julie, do we have any more time? Like maybe one more? Okay, one more quick question. Is Emma's mom, right? Yeah. Okay.
Just with the ethics, and you don't have the full right for best interest of your child, and making decisions, the doctors have to make those decisions as well. Who decides if it's in the best interest of a child to not receive treatment for pain conditions that's available to adults, but they refuse to provide for children that's available in your state if you're 18, but not until then?
You mean, are you asking who gets to decide that, or are you asking why they get to decide that?
Why do doctors get to, on one hand, look into the best interests of the child and might disagree with parents because they're going to protect that child if the child refuses treatment, or a parent refuses treatment? I understand that. But if there is treatment available to a child, why is the doctor not responsible to provide that to the child if it is in the best interest of them?
I would say that, so that is a question.
Ketamine infusions for CRPS.
Yeah, okay. So I actually have some experience with cases with ketamine infusions, and I would say in ketamine infusions specifically, what I have most often heard from the medical community is that it may be acceptable for an adult patient to take some of the inherent risks that come with ketamine infusions, but it is not acceptable for a child to take that the risks are too high. And so a provider will usually say that there's too much that we don't know about it. It's still an experimental treatment, and an experimental treatment is inherently riskier than one that has been extensively studied, and that when it comes to a treatment with higher risks than other treatments, we tend to want to avoid them as much as possible for children, because medically speaking, from an ethics perspective, it is our obligation to minimize risks to protected populations. Not always, not exclusively, but we do want to minimize risk when we can. So if there's an experimental treatment available that we still feel is somewhat risky or is very risky depending in the doses of ketamine, it can be very risky if you go really high doses, then most providers are going to say it's that doctors are ethically obligated to err on the side of caution until the patient is old enough to accept those risks for himself or herself. Yep. And that's not always a very satisfying answer, and I just want to acknowledge that. It can be really, really unsatisfying for both parents and for children who are old enough to know what they want. But that is legally and ethically how we've sort of come about it. Yep. Okay, and I think